All right, I think we're good. So our next speaker is Regan Baum. She is a PharmD at the University of Kentucky. And when I said, "How would you like to be introduced?" she said, "Regan's fine." So, okay, well, we need a little more than that. But anyway, Regan is our local PharmD expert and probably a nationally recognized expert, if I had to guess, because she has a brilliant mind. So with that, Regan, I will let you begin.
Thank you. Thanks, everybody, and so much for having me here today. I'm really excited to be talking about this topic. So I love treating snake envenomations. I love learning about snakes. And part of it is because it's one more way here at the University of Kentucky that I get to provide bedside patient care. So at our institution for a little over a decade, the pharmacists have really been the ones that have helped come in, assess patients, and manage these envenomations. And so it's pretty cool. But what I really want for you all coming out of this lecture is to think about a few things. I think we can't have a lecture in today's day and age without somehow wrapping back around to COVID-19. And I am not going to be the exception. So I think as parks open back up, so this is a picture from Zion in late March before everything kind of shut down. I think as parks open back up, this cabin fever really starts to grip people. I worry that we're going to have people that are slowly begin encroaching more and more in on some of this wildlife. And will we see more envenomations this year? I am in Kentucky, so sort of in the Southeast. We consider snake bite season to be April to September, so we are in it as soon as it starts to warm up. We know that these things are going to happen. So what I want is for you guys to maybe have a few tips for if you're out or with a loved one, what are some things you can do if somebody is bitten? I want you to have resources for, if you're in the field and you're bringing someone into an institution like mine or another outside hospital, what are the things that you can do that will help us? And then how do we sort of approach snake bites when you get people to us? So this is just a nice graph that kind of shows the numbers of envenomations and the number of deaths around the world. And you'll notice that in the US, really the number of envenomations and the number of deaths is pretty low. And part of it is our snakes, part of it is our healthcare resources. There's a lot of disparities in Asia and sub-Saharan Africa. And the World Health Organization has really made this a big priority to try to increase access to anti-venoms around the world. But with them being relatively rare and very expensive to make, there's a lot of disparities. So there are so many snakes. There's more than 3,000 snakes, more than 300 venomous snakes around the world. In the US, we really primarily have two families of snakes, so the Viperae and the Lapidae. The crotalus snakes, which include rattlesnakes, water moccasins, and copperheads, which are the three snakes that are listed on the right side of my screen there, are the most common snakes that people in the US come into contact with and are bitten by. The Elapidae is actually what our coral snakes are. So in Texas and Florida, parts of Arizona, you can run into some of those snakes. The Colubridae is actually a family of snakes. It's the largest family of snakes. The corn snake is one of the snakes that we have here that's not venomous, that is in that group. Also the boomslang that's in Africa might be another snake that that's in that group. But there's no way for me to cover all of these snakes in 25 minutes. I wouldn't even be the right person to cover these snakes in 25 minutes. What I'm going to cover is what I know, right? So what I know is snakes that are indigenous to my area, which are also very common in a lot of America. And so I'm going to kind of stick to those. So if you are in an area of the world or you are in an area of the country where you don't have these type of snakes, you need to know what's around you. And the reason why you need to know what's around you is because venoms are very complex. Okay, so venoms are very complex mixtures of proteins, enzymes, and they all do different things. And the goal of the snake is actually not to bite a human. That's not what they want to do, right? They want to bite some food, mouse or something, right? And they either want to immobilize it with a neurologic toxin or they want to do something to help themselves digest it and eat it better, right? So when you think about the effects of these venoms, we do see effects in humans that sort of mimic what the snake is trying to do to prey. So, for our snakes in the US, and certainly in my area, the majority of the toxins are local toxins and hematologic toxins. It's less common that we get a lot of the neurologic symptoms with the pit vipers in the US. All right. So the thing is usually when I talk to people, I hate standing in front of a screen and just talking to audiences. It's my least favorite thing. So if you've ever been to one of my lectures, you know that I always pick on my audiences. And so I'm going to try to do this here via the Zoom link because I just feel like it's a little soul sucking for me to just sit here and talk at you. So what I'm going to try to use is the chat feature of the box. And I'm going to go through some myths and some things you should do. And we're going to test your knowledge base. And I would like you to use the chat box and just type yes or no or Y or N, whichever you like, as we go through. And I'm hoping that I can see the chat box, and maybe I can't. Hang on. I don't know if I can, but we'll just go through it, and I'll give you guys a few minutes or a few seconds to answer. Hang on, here it is. Maybe.
If you want, I can give you the gist of the responses.
That would be great. I don't think I can see it because I don't have two screens. All right, so I have so many pictures of snakes in jars and snakes in bags and snakes in coolers. I don't know why I keep taking pictures of them when these things come in. This is obviously like a patient belongings bag. So when possible, a snake should be brought with you to the hospital. So yes or no, should you bring that animal to the hospital? So if we get a couple answers, Floyd, you can kind of tell me what we got.
I think we've had 6 or 7, maybe 8 yeses. The majority are saying no, and some say to take a picture.
Good, I like it, I like it. All right, so I'm gonna be really honest with you. I am sort of a worst case scenario preparer for. So if you bring me a live snake to a hospital, my worst fear is that that live snake escapes, all right? I also think that the only scarier thing than putting somebody in the hospital with a live snake crawling around might be a buggy with a live snake. I don't know. So here's what I think, and most people will agree with me. I do not need you to bring the snake to the hospital, not alive. I certainly don't need you to kill it. You know, we know that these things sit at a fragile place in the ecosystem. You know, they do have an impact in the food chain and that sort of stuff. So I am an advocate of, look, please don't kill the snake. Please don't bring the snake with you. Alive or dead, it is really not necessary. And I think when you think about scene safety, it becomes very, very important. So every year we get a handful of people that have tried to kill a snake. You know, the snake bit their kid. They feel like they have to kill the snake. They have to bring the snake to us so that we know what we're treating. And in reality, we really do not need the snake. And so as you guys go forward and you're thinking about this, really the priority when you're on the scene, if you respond to the scene, is scene safety. You know, and when we're going to go about identifying the snakes, I think everybody has seen images like this talking about the ways that we can identify snakes. I think this is a nice picture. I think you have to realize the limitations of this picture. So this is only for crotalids, it's only for pit vipers in North America. It doesn't necessarily work in South America. It certainly doesn't work in Africa and in Australia, right? None of these rules hold true. I do think it's kind of fun, like the scales underneath the tail, like you would get close enough to the snake to look under the tail. However, if somebody does chop the head off of it and bring it in, you can't actually see that. So, but it's hard to get close enough to the snakes to be able to tell. And then you have to worry about, you know, are you putting yourself at risk, and you do that. So the people that said, hey, a photograph is fine. Yeah, you are absolutely right. A photograph is fine. And preventing secondary bites is probably one of the most important things that I think that we can do. And when you guys are responding to scenes or talking to people that you love that hike, this is probably something that we can tell people, hey, you know, leave the snake alone. We don't need to cut it to come to the hospital. So good job, everybody that answered that one correctly. All right, next question. A tourniquet or pressure bandage immobilization is indicated for rattlesnake bites only.
Mostly no's, no. Negative, no.
Good.
No tourniquet at all. Any yeses?
Any yeses? What about pressure bandages? Any yeses on pressure bandages?
Or venous constricting band?
Mm-hmm.
Walt Lover said yes.
Devil's advocate, I love it. All right, so let's talk about tourniquets first, okay? Tourniquets are a no, all right? So in North America, for any of our snakes, a tourniquet is not indicated. You know, what we know is that it probably leads to a higher incidence of limb ischemia. It leads to a higher incidence of gangrene. Probably the best study with tourniquets in crotalid snakes was actually done with the South American rattlesnake, and it was about 100 patients, and they did a pretty good job of matching them on time to hospital, time that tourniquet was in place, and they found no difference. And that snake actually has a much higher incidence of neurotoxicity than what our patients have in North America. So there are certain areas of the world that do use, more pressure bandages and tourniquets, but those are normally for snakes that do have really potent neurotoxins where, you would quit breathing and things like that. So in North America, if it's a snake that's indigenous to North America and you roll up on the scene and somebody has a tourniquet in place, no, right? Really not indicated in our patient population. I think what's harder is this pressure bandage. And part of this is a little bit clouded by recommendations came out in 2010. And so I think because of that, we still see some of this that happens occasionally. I had one last year that rolled in with it. And what happened is they came in and said, yeah, it's probably a good idea. It prevents the venom from reaching systemic circulation. However, most toxicologists agree, and I agree as well, that when you do that, probably what you're doing is allowing the venom, which is a really nasty local toxin, to just sit in that limb and cause more problems, right? More swelling, more erythema, more pain, increased incidence potentially of compartment syndromes and that sort of stuff. So what I would say for pressure bandages and tourniquets is no, right? Not for our snakes up here in North America. Now, if you arrive to a zoo and they have some, very exotic snake where they have that in place, then they may have protocols because that snake may have a little bit different venom makeup than what our normal snakes do. Okay. Remove tight jewelry and clothing. This is hopefully an easy one.
All yeses.
Good, yeah, right. So I've just told you that a lot of the effects of our snakes are local effects, right? So that means a lot of swelling, a lot of erythema. So anything that we can do to, if we leave a ring on and it gets stuck, we're having to cut it off. We could compromise circulation to that limb already. We already know that's going to be a problem because of the swelling that's going to happen. So this really is very, very imperative, and it's very imperative that we do it early. And it's an easy, safe intervention to do. So good job, everybody. That was an easy one. How about ice and elevation? Should we ice and should we elevate?
We have a yes, multiple no's, 4 or 5 no's. So no, not always, no. Mostly no's.
Okay, good. So what I was taught was that snakes hate cold and so do their venom, right? So probably in reality, an ice pack, for 15 or 20 minutes, if it made the patient feel a little better, is not a big deal. It's probably not going to help, but it's probably not going to hurt either. Probably what would hurt is like pretty intensive cryotherapy or like immersing someone's hand in a cooler of ice water or something like that. That we know can cause a lot more tissue injury at the area. Okay, so ice is probably a no, right? Elevate, so elevate, we elevate at the University of Kentucky. I know our friends to the south elevate at the University of Kentucky as well. And you will hear people on both sides of this, and the rationale is either one of two things. It's either, if I elevate it, is that going to cause the venom to leave where the bite is and travel more back towards systemic circulation, right? More back towards the heart. Or what we say is, we know that our snakes cause pretty profound tissue damage, and is it better to elevate it to sort of minimize the swelling? We know that it helps with pain. And so that's why we are big proponents of elevation. What I will tell you is that if it's hard for you to elevate based on where you are, a neutral position is okay too. This is not something where if it's hard to do or the bite is in an awkward place where it's hard to elevate, the jury is a little bit out on that one. Documentation of progression should be started in the field.
Looks like all yeses and absolutelys.
Good. Yes, please, please. This helps me so much. This is probably the most helpful thing that you can do for me, because the thing is we can't tell in the field. You can't tell in the field if the bite is dry. You won't know, right? And probably 20% of bites are dry. And some symptoms don't present until much later. You know, it can be 8, 12, 14 hours later before symptoms really are starting to be seen. In some of the rarer cases. So the venom progression or marking that leading edge of swelling or redness is really, really important. And it's really important when I do my assessment to be able to figure out, is this a person that's going to need treatment with an anti-venom or not? So, you know, grabbing a pen, you can see on this one, they have the time marked, marking the time along the line. You know, if it's progressing really quickly, mark it multiple times en route, right? If it's going, you know, if they're bitten on the finger and it's going knuckle, hand, wrist, elbow, and you're having to mark it every 10, 15 minutes, I'm fine with that, because what that tells me is that's progressing much, much quickly, versus if you have a dry bite, they tend to not have a whole lot of any of that. You know, you may just see the bite mark. So you guys doing a good job of this is one of the most important things that I think that you can do for me. Oral suction is advisable for all bites unless you know that they are dry. So I don't know about you guys, but my parents had one of these in their first aid kit when I was growing up. I remember playing with it. You still
have not seen one yes.
You good. I'm glad that there are no yeses, right? So sometimes with this slide, I show like that City Slickers clip, but nobody knows what that movie is anymore. I think I'm not that old, so I don't understand how. But anyway, regardless, oral suction is not advisable. So there has been a trial that kind of looked at it to see like it was obviously mock, right? But it doesn't remove a substantial amount of venom and probably introduces oral flora into a wound, which is just not a good idea, okay? And so we don't do that. A lot of these snake bite kits actually do have some oral, like some mechanical suction devices, also not advisable, okay, for some of the same reasons. We know that it probably causes more tissue damage to the area. So if you see these devices, you see friends with these snake bite kits like this, the best answer is probably no, we shouldn't be doing that. So nope. All right. Laceration or bleeding of the bite increases blood flow and minimizes venom absorption. So I actually bought this exact kit last year at our local outdoor store for my residents. So who is a yes or a no on this?
I think all no's have not seen a yes.
Yeah, I bought it as a gag gift. Okay, like let's be honest. It still floors me that these things are out there and you know, you can still buy them, but it's pretty interesting. So suction, there's a scalpel in there, there's a constrictor, the antiseptic wipe. Probably not what we need up here. So if you see these, you see people using these, you know, what we know is that this just causes more local tissue damage and is really not advisable for our snakes. So that is a no. So good job on that one. All right, this is one of my favorite ones. So baby venomous snakes are more dangerous than adults.
This looks like a mix. Almost 50-50.
So I think what happens sometimes is you get people that are out and they're like, well, the snake was 4 feet long, so, you know, it's probably okay. And, you know, some of that dogma is rooted in older snakes are better at controlling their venom. And yeah, older snakes probably are a little bit savvier snake. They've been around a long time. They know intrinsically that it takes a lot of energy to be able to produce the venom that they produce and that they need it to eat, right? So they're not probably going to waste a whole lot of their venom and they have the ability to control it. However, what I will tell you is that, you know, a diamondback rattlesnake, an adult, can probably produce upwards of 600 milligrams of venom, right? Versus a small juvenile, like the small snakes there, may only be able to produce 70. So there's a lot more venom in that bigger snake. So it is really hard to say, based on kind of that old adage that one is better than another and that the baby snake, you know, yeah, probably it doesn't have as good a control, but realize that, you know, when these snakes bite, they don't generally drop their whole entire venom load, and your bigger snakes do definitely have more. So I think it's really hard to say baby snake versus older snake. You're always safer. It's always going to be a dry bite with an older snake because it's just not. You know, there's a lot of variability in the venom makeup of different snakes. Even snakes in the same area, copperheads or rattlesnakes from the same area, depending on their age and time of year and what they've been eating and all of that sort of stuff. There's a lot of variability. So I think you have to be a little bit careful with this old adage that baby snakes are more dangerous than adults, because I think there's a lot of pieces to it. So I'm going to say no, but I understand the basis, right? And I think that that's what's important, is that we just don't be dismissive of it, right? Okay. Benadryl is safe and effective for treating snake envenomations.
I saw a yes, mostly no's.
So I think some of this comes from veterinary recommendations or veterinary websites. Some of it comes from people using Benadryl for things like bees, right? Bee venom. And if you think about the way that when you get stung by a bee, it actually activates cells in your body that release histamine, and Benadryl is an antihistamine, so it could help, right? But the problem is that for snakes, what we have is local tissue destruction and dumping of intercellular contents because of that. And it's not a histamine mediated reaction. And so Benadryl is probably not going to help us in any way, shape, or form. And it's probably not even something that most people agree would even be a good temporizing measure if you're out in the middle of nowhere or something like that. There are instances of people having anaphylaxis or anaphylactoid type reactions to venom. What I will tell you is if you have somebody truly having anaphylaxis, the treatment is epinephrine, right? The treatment is not Benadryl, the treatment is not steroids. Those might be adjuncts to therapy that we might use later to kind of help mitigate, but true anaphylaxis needs epinephrine. And so really epinephrine probably doesn't need to have a role for us. What about NSAIDs and adjuncts to treat pain? We know that these things, because they do cause a lot of local tissue damage, that they are very, very painful. So what about NSAIDs?
A few yeses, a few no's.
So
Yeah, it's a mix.
It's a mix, yeah. So most of the time what we say is NSAIDs we should probably avoid. And it's because of the way they work on platelets. We know that our snakes also have some hematologic toxicity, and we worry that adding this on board, do you potentially increase the risk of bleeding? And we don't have any trials that tell us that it does, but I think mechanistically that's what we think. You know, usually if you get envenomated by one of our snakes, it hurts really bad, and probably something like an NSAID isn't going to be enough. So these are probably people that maybe do need opioids most of the time. Things like Tylenol might be okay if you're en route and that's what you got. But generally what we say is avoid your NSAIDs as a class. All right, this is my last big question for you, and then we'll kind of recap, and then I'll take any questions that you have. I think I'm doing kind of okay. I'll go fast. All right, all patients should be brought to the hospital for medical assessment.
Almost unanimously, yes.
Yes, thank you so much for knowing that, right? So the thing is we don't know if bites are dry or not, right? And we won't know for a while, okay? So unless you're able to like see the snake and you know that the snake is non-venomous and it was kind of like a call that didn't need to be made, those are probably few and far between. Most of the time the snake is long gone. People should be brought in for assessment. That's probably the safest thing, okay? You know, when people get to us, we do a lot of the same things that you get. You know, most people that are going to be envenomated by snakes are going to be envenomated on the extremities, you know, so that's where the majority of our issues are. And most of the effects are initially local. You might have some later hematologic effects, but, you know, unless somebody is bitten on the face or the neck where you have airway and potentially ABC circulation type effects, which are rare and few and far between, you're going to manage those just like you would the ABCs. You know, so for me, I want to look at the area of envenomation. I'm going to be tracking, what did you guys do? How did you mark it? How fast does it look like it's going? You know, we will get some laboratory parameters and continue to mark that leading edge of swelling. And then not everyone that comes to the hospital is going to get anti-venom, you know, so we really look and take it on a case-by-case basis and kind of determine how severe does that envenomation look like. And most of the time we're treating things like either coagulopathies or progressing local effects to try to kind of mitigate some of the progression. So just kind of to recap, you know, the majority of the bites are to your extremities. Okay, so if bites to the head and neck obviously would be of much higher consequence, and your ABCs and managing those would be very, very important. Allergic reactions to envenomations are rare, right? But that would obviously also constitute a higher level of emergency. Scene safety is probably the most important thing that you can take, right? So we don't need the snake, we don't need the live snake, we don't need the dead snake. A picture of the snake is fine. Either way, even if you don't have a picture of the snake and you're not sure what it is, it's probably going to be okay. We're still going to manage you for our snakes in North America the same way. But just preventing a secondary bite is probably the most important thing. You know, keeping people calm on the scene is important. It's really hard to tell if bites are dry, but probably 25% of bites are dry. And most of the time, you know, you have plenty of time to get somebody to a hospital and get them medically managed well. For Kentucky, what we say is nobody has died. So 75% of our bites in Kentucky are copperheads. What we say is that nobody's died from a copperhead envenomation that adequately got treatment in a reasonable time manner, right? So we're pretty fortunate in the US that our snakes, when people are bitten, are pretty well tolerated. Avoid tourniquets, avoid oral mechanical suction, don't do anything crazy with cryotherapy. You'll sometimes see things like about electric therapy to denature proteins, none of that stuff, right? What we want is, you know, if you want to do first aid on the way to the hospital, great. You can immobilize the limb, but we would not use any sort of pressure bandages or tourniquets. And that, you know, coming to the hospital is really, really important so that we can evaluate the progression of envenomation and figure out if more treatment is needed. So at this point, if anybody has any questions, I will take them.
We do have a few questions. I will put two of them together. One was, is the potency the same between adults and baby snake? And what is your recommendation for pain management pre-hospital?
So for the adults and baby snakes, I think it depends. So there is some stuff that says yes, and there is stuff that says no. So for like the diamondback snake, I think the adult venom can sometimes be a little bit more potent, but it changes so much, right? It even changes if you collect snakes from the same area, depending on what their diet is and that sort of stuff. So there's just not an absolute answer for that question, unfortunately. Pre-hospital pain, probably opioids is probably, you know, and there's a lot of things with opioids. When you start selecting opioids for people, you have to think about a lot of things, you know, people that are on opioids at baseline and, you know, Suboxone now and all that sort of stuff. I think Tylenol is okay to give as well, but just realize that most people have some pretty profound pain with these bites if they're truly envenomated.
Okay, and what about ice for analgesia? And what about cleaning the site with an alcohol-based product?
If you want to clean the site, basic first aid measures, that's fine. Is it something that I think should delay you getting somebody to the hospital? No. Ice for analgesia, it's not going to harm, right? And it may, I don't usually have people that feel like there's a whole lot of benefit to it. I think because the pain is pretty bad. I mean, I think if you want to try it, I think it's reasonable. If the patient feels more comfortable with it, I think it's reasonable. So probably won't help, probably not harmful. As long as you're not sticking it in a cooler of ice water or, you know, hours and hours of ice in transit to the hospital, which we know is probably bad, not a good idea.
All right, we're getting a lot of questions. Would you mind answering some in the chat?
Yep.
If you have time. I have one
Yep.
quick question. If
Yep.
you have a prolonged extrication, let's say it's someone that's in a rural area and the patient can walk or you can carry them out. It would take longer to carry them out, but faster to walk them out. What should be done? What's the preference?
I think, you know, I think whatever if you have somebody that's relatively calm that you feel like you can help them hobble out, that's probably, I think, getting them to the end game, which is the hospital, is probably better personally. But I think that that's kind of a call you've got to make on the scene based on how far in you are and all of that sort of stuff, you know, and how long it's going to change your transit time. I'm going to be honest, for that sort of question, I would probably defer to like you guys that extricate these people all the time. You know, is it a 5-hour difference? Is it a 6-hour difference? Is it a 10? Like, you know, it would kind of depend on some of that. You know, fortunately in the US, our snakes, you know, people do pretty well.
All right.
All right. Thank you
Thank
all.
you, Regan. There's a bunch of questions in the comments if you
Okay.
have time.
All right. I'll try to get some of them.
All right.